from Professor Erika Mendoza.
Thank you again, Elena. As always, impressed with your idea and with the results. So I will share my screen and start just very little of theory, and then go to a patient, a very lovely lady I have here with me. Of course, this activity is sponsored. So why compression in ulceration? Because we have, for example, varicose veins filling the place here. So this high pressure goes down, and the first step, and always step, if we have an ulceration and it is a venous ulceration, we have to put compression on the leg. And the German guidelines are very clear and say you need knee-long compression, and you can put the other if you want, but as the compliance is higher, knee-longs, it is very important to use knee-long, because the ulceration never will happen in the thigh, it will always happen on the calf. So which options do we have? We have bandages, we have compressive stockings, we have ulcus stocking systems, we have medical adaptive compression systems, and we will show you one of each or two of each, and show you how to do it and which are the pitfalls. We have several types of bandages, and it is very clear: do not put the raw bandage on the leg. This was in the earlier times where we did not have all these wonderful things we have today. Because for the first, if you make a double layer bandage, it will not go down, it will adapt to volume changes, and it will not hurt the skin, because you have a soft underlying bandage. Like if you really want to use this kind of rubber bandage, you need to put something soft below, but the German guidelines are very clear: this one is obsolete, we need something double layered. Do not spare material. This was a lady with, very creative. I do not have to comment on the nonsense of such a bandage, but this was a lady bandaged with a double layer system by a technical a lady going there. She was supposed to be a nurse, but of course this is not good. And I never know if this happened because the patient unfolded and put it again, because I can't imagine this to be done by a professional. As you see this very profound furrows, there is a pressure place which could provoke a new ulceration here. And the start was done like at a point where beyond the toes, and this is favoring a big edema in the toes. So this all should be avoided. Do not apply these things to the leg. And this is one of my highest, I don't know why people are so stupid. How can you pack this and then tell not to use these metal clips? Please do never use metal sharp things on a leg, especially if you are trying to get rid of lesions on the skin. So this is really something I don't understand. We have these wonderful multi-layer systems of different enterprises with different helps. I will use one where there are the soft bandage is cohesive, so it won't, if I apply it, it won't go away. And you have to always be aware to have a 90 degrees angle in the foot and to do it overlapping. And then you have a second layer, which is adhesive. Never put adhesive layers on the skin. You can put cohesive because they adapt to themselves, but adhesive to the skin is not good. And then you have, when you finish, you have a bandage which will stick like 2 or 3 days, depending on the volume change you will expect on the leg. But normally this is really good placed on the leg. And so now we go to the demonstration. I was told to stop this. I remembered. And I go, and here we have the leg of Leonie. Leonie is a young lady, very healthy, but we painted the varicose vein, the skin discoloration, and this black thing is supposed to be the ulcer. Everybody sees the ulcer. This is our friends today. And we want to do lots of things with this leg to get rid of the ulcer. Of course, they could start making the punch, but I think I won't do this to my friend Leonie today. So this is the double layer system. This one is from Hartmann. This is the cohesive. It is not adhesive to the leg, but it is adherent in itself. And you have to tell the patient, shall we say like, remain like this? Is it better to be seen? Yes. Okay, we start at the line of the feet. We don't put the first line below the feet because of course the patient will be walking on it. And we start with some, of course you should do better underneath, 90 degrees. There are lots of schools how to do this. To make first like this, be very careful not to make furrows here, and go back to the ankle and down to the foot. The thing is, when you start, the foot has to be covered properly. This region has to be covered properly, it shouldn't be open. And the good thing with this cohesive bandages is that even for a person not used to do it every day, like you will observe, the bandage will stay in place. And now we go on, going up on the leg. This part of the bandage is not so stretchy. It's a short stretch bandage. And it is important to roll up the bandage on the next to the leg, not make like this and then like this, but doing it directly on the skin. First, you avoid furrows, and second, you have a better feeling how it goes, how it lands on the skin. This one is not so important to make it stretchy because it's just also a protection of the skin. And the enterprise says, if you are strong, there is a scissor recipe on Google House, right? Genau, darunter I'm not strong, I need a scissor. The camera team is very, very versatile. They help also with the signals. And it is cohesive, it will stay like this. And then you go, this one has a longer stretch like the other one. It is still a short stretch. And it is idiot sure safe because you have to convert this rhomboid things into like nearly round things. And you start again next to the foot, and you should never go like this. Always should leave a little bit of the white to avoid this adhesive thing directly on the skin. And again, the foot is always the difficult part. You go up and you go down again. The problematic thing with these bandages is that to anchor them on the foot, they will not fit inside a shoe if they come with normal shoes. And I learned from Professor Pratt, whom I really loved, that you can use stockings. Normally, if the patient has an ulcer here or has a real big edema on this part of the leg, and he has already a stocking, you can put his stocking and make the bandage over the stocking, starting like only here. And he told me, like 10 years ago, and since then, if people comes with little tiny shoes, I want to start fitting them, it's not smart, then I use those stockings as the first layer and then go with my bandage from them. But if they resist and the bandage is not too strong, you will have a good result. This one is supposed to be a 25 to 30 millimeter Hg pressure if you convert these ones into round things. So don't make more layers than necessary. Here again, it's supposed to be able to cut it. Here, you never put, please, this metallic things. You can put, you can apply, I look at it now, can put this, tape, oh my God, my English, like telephone, you can put it here, but it will also stick. You see, I know, it's the air, it won't. I say, camera team is perfect, and I don't know the name of this in English. I'm sorry. Okay, the patient can move a little bit the foot, but as Elena also said, it is important if you have an ulceration that, for example, the movement is less at this moment, just to avoid the frictioning of the surfaces. How are you feeling with this? Great. She's feeling great. We have to look at the toes with the other one here. A much different color. This is very important when you finish, because if they start to be white or dark blue, it's obvious that the thing is too strong applied. Yes? So this is the double layer bandage. And this is usually the thing to start with, because when you are in an office, normally you don't have a complete battery of all compression devices in the correct fixing. And the second thing is that if you have a very swollen leg with an ulceration or without, and you put any device on it, you will have to get a new device or a new stocking when the volume has reduced. So the correct way is start, in case of a real large edema, start with the bandaging, and you can leave it some days. As we heard from Ellen, you will leave it 3 weeks. But my experiences, I mean, in Germany, the guideline says if you have a lymphatic edema, you have to make the complex treatment with every day and with drainage and bandaging and so on. I do not find any therapist who gives me lymph drainage daily tomorrow. We have to wait for months sometimes. So my solution is I make this and ask the patient to come back next day if the edema is soft. And normally they lose like 4 centimeters at this point and 3 to 5 centimeters at this point. And then I start adapting in combination with the orthopedic enterprise stocking or a wrap or whatever we will play. So now I give my assistant, I will introduce Rita. Rita is a wonderful worker of Sigmaris. She's with me since 15 years, I think so. Okay. And Britta will unwrap the legs while I introduce you to the next step, or we can discuss this. Now, please remind me that I have to put, I forgot to put a wrap on the ulceration. I have to do this with this next one. Okay, so we are back here. Any questions to the wrapping?
Excellent. Thank you very much for a great demo of wrapping, a lot of tips and tricks that we have seen with the 2-layer bandage. I have a question here. Someone asked, when you wrap the bandage, how much do you cover the previous bandage? Do you leave 1/3 exposed or 1/2? Because you did have very nice way of wrapping it.
Yes, I just try to leave, I mean, 1/2 centimeter is enough. Just to avoid that the skin is touched by the adhesive layer, because this makes like itching.
Okay, brilliant. And I got another question. If the patient has saphenofemoral junction incompetence, would you go above the knee with the wrapping, or would you still until below the knee?
So if he has a saphenofemoral reflux and I treat it like I do abdominal or something, then I would do that after the first decongestion phase, and then he would have a stocking until the thigh. But on the first day, I only would use the wrapping for the decongestion phase, and the edema, the venous edema, is always at the calf. So you don't have to treat the thigh, because On the other hand, if you start walking with a wrapping to the thigh, with a bandage until the thigh, sorry, not a wrapping, a bandage until the thigh, it will, by the best luck, when the patient arrives home, the bandage will be gone. So the over knee bandages are very, very difficult to have them in situ. And normally the edema is not that high at the site. Sometimes if you have patients with a really, for example, cancer, they had a lymphoma in the thigh and they have a real high pressure edema in the thigh, then I bandage them and recommend them to lay down and put the leg up, because every time they stand up, this edema will be reinforced. I bandage them to the thigh, or I send a nurse to them at home to bandage them, and I give them intensive manual lymphatic drainage. Those are really those where I say this is necessary to do it now and start now, because they suffer a lot. And then you can put a stocking to the side, but you should not, for an ulceration, you don't need to bandage until the thigh, even though the reason is in the thigh. Yes.
Okay, brilliant. And if my co-moderator, Dr. Elena or Dr. Mahmoud, have a question you like to ask about the wrapping technique, it's a very nice demo, really, that we really used. Do you have any questions or remarks?
I have one question from my side, being working with such patients for many, many years. I think one of
Yes.
the big challenges is actually the compliance also from the patient. So how you see the compliance from the patient regarding the wrapping with the bandage, especially if they need to take showers and change and do things at home? Yeah.
This is why I tell you, other than the guideline says, when you have a soft edema, when you can make you can make a hole in it with a finger. My experience is if I make this bandage, the next day, all this extra water has gone. So I explain them. I bandage you today, or if you can't because you are going to dance this night or something, you come back tomorrow. We leave it 24 hours and have a person for measuring the stocking prepared, and if possible to give you the stocking immediately. So it will be 1 or 2 days with the bandaging. But you can't imagine how many old people in Germany don't want a stocking, but want this bandaging. And I always keep telling, but if you have a stocking, you could walk, you could move, which is at least the highest interest, to keep the people moving and to move the ankle, to have the muscle pump going. But the ancient people wants bandaging. So it takes a lot of time to convince them not to have bandagings. And the young people, they accept, because nobody, I can't believe you. I have this since 3 years and I can't believe you. Next day, you make a picture, we show this massive reduction of volume. It's impressive. Yes. But I would never
Excellent.
have somebody with this for more than 2 or 3 days. Just in case you need a flat knitted stocking, for example, and it is not there, or the wraps in Germany, they are not reimbursed immediately. You have to make a request and so on and so on. And then until it arrives, you will have to be bandaged like this. Okay?
Excellent. Yeah.
So then,
I have a,
Yeah.
yeah,
yeah, sorry.
that's
Sorry,
okay.
sorry.
I have a question. You deal with a lot of old patient, maybe living alone with social circumstances. This kind of wrapping cannot be done by the patient himself. It has to be done by nursing staff or a unit like what you have, a great unit in your place. Is that right?
Yes, and perhaps the reason why they want to be wrapped is bandages is because then at least once a day somebody comes to visit them.
Yes.
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 Perhaps this is the reason.
Yes.
It
Yes.
could
I
be a
totally.
psychological one. But I
But-
tell
but-
them
but-
always, if you get stockings, and lots of them are not able to don the stockings by themselves, the nurse is coming to don your stocking. But on the
Yes.
evening, you can go and have a coffee with your niece, which you wouldn't be able if you are bandaged. And this is like the psychological way I catch them.
That is why the PhD in psychology is very important, the one that
Yes.
Dr. Elena had. It's very, very important to have this psychological impact of compression. And we know how important compression is to venous ulcer. Any modality, either you're using a vacuum, you're using sclerotherapy, all the modality we know are plus compression. And always interesting. Yeah, always interesting how much compression play a role in the treatment and how much other modality play the role. There is no modality that has really got us out of using a nice compression. That is great. Very nice question and very nice demo. I'm very, very happy with this.